This morning I'm going to show you a modified version of the Wilson osteotomy that some of the members of the Academy of Ambulatory Foot and Ankle Surgery are performing. The first guy who showed this to me was Dr. Burton Katz, and it's sort of his modification. So we're trying to work on some publications with this. It hasn't been done in the literature before with a slight variation of the newer cut here. I want to show you the patient. This patient now is pretty much post-op, about 8 months or so now, so I want to show you an 8-month follow-up. Well, I use this procedure for two reasons on this patient. She had a bunion deformity, and she was a pain in her joint, so she needs some decompression performed too. So we did this decompression and corrected some pasta by taking a little wedge out immediately. So anyway, I'm going to show you the pre-op x-rays, the post-op x-rays, and I'm going to show the patient clinically today. So we're going to have the patient kind of stand up on her foot. Stand up, we can show her foot now. So you can see now we got good correction of her bunion deformity. Her bunion deformity was not a real severe bunion. Most of her pain was on the dorsal aspect here and with movement of her foot. Now before we did this surgery, well, how much pain were you having in your foot? Was it pretty painful for you?
Yes.
So on a scale of 1 to 10, how much were you pain before the surgery?
9.
So she had a 9. She's saying she had a 9 of pain before the surgery. Now we're 8 months later. Any pain with your foot now?
No, sir.
So 0 pain now. We went from a scale of 9 to 0. And you see we got good toe purchase. If you look on the side here, move your foot up and down for us. See your toes, good movement. She purchases all the way to the ground. This is a very good procedure. You don't get dorsiflexion of the first metatarsal, I'll show you on the x-rays. That's been some of the criticism. Now her, I did K-wire fixate. I sometimes fixate percutaneously because I'm more comfortable with that. But I've done these also without fixation and with excellent results as well. I'm going to have her sit back down. So we're going to kind of look at her foot here. We're going to kind of review some things here. Before the surgery, when I loaded her foot and tried to move her through range of motion in the first metatarsal phalangeal joint, she was having a lot of pain. Now you can see the way we approach this bunion correction. We do this from a dorsal approach here. I go close to the tendon here, so you stay away from all the nerves here. And this is where our osteotomy is performed on the top here. The 2 K-wire fixations were put right here, so you can see some marks here. That'll go away. So I want to show you something with her foot. With her foot even loaded in root neutral position, look how much movement we now have in the first ray. See? No crepitus, great movement in the joint here. So she has some issues with arthritis in the joint, which has been relieved by some of the decompression we got from the osteotomy, and a good actually anatomical and cosmetic result too, because she has some bunion here. That's actually going too. Now what I did with this, we kind of push it and actually plantar flex it. And you can do that by manipulating the osteotomy slightly to get a little plantar flexion. Not a lot, didn't really need a whole lot. But this is stabilized her foot. If you see in her first ray now, her foot's stabilized. If you move the first ray, compare that to the second ray or even the 5th ray, you can see we got a good stable first ray now. So her symptoms have abated as a result of this minimally invasive surgery with percutaneous fixation. Show you the Katzen modified Wilson osteotomy, and what he basically does, he starts in a dorsal part and drills at about a 45-degree angle directly through the bottom. So the osteotomy starts like this, and it's directly straight through, and you can see as you go through the bottom, I'm going to kind of exaggerate going through the bottom, but that's how it looks in the bottom. Of course, in a real specimen, you're not going to go for. I'm just showing you what it is. So that's the first cut. Now the way the guys in the academy originally did it, they went ahead and finished the cut medial and lateral, that caused shortening of the bone. So what Katzen does, he pulls this back up, and then he goes back in the same way, this time only part of the way through. So he goes in, and then once he's about halfway done like that, he begins to make his dorsal cut. Now, you can angle this cut different ways. If you angle the cut this way, you're going to preserve length of your metatarsal. If you angle the cut this way, you're going to shorten the metatarsal. You could also plantar flex it theoretically by taking more from the lateral side you do from the medial, which is what I normally do. So once I'm here, what he does then, you can use this as a fulcrum. So you come here and you go ahead and cut the medial side. That's done this. Now this is a pretty safe osteotomy because basically you're inside the capsule. Now you go back through the same hole, and if you wanted to make sure you maintain length, you're going to cut more towards the longer part of your second med. So now you're going to cut through here like that. So then essentially what you have is a cut like this. I'm going to clean this out just so you can see what the cut is. That's how the cut on the top looks. You see that? Now what you do to finish your osteotomy, you go back through your original hole, which you can feel like this. And from this you're going to maintain that same angle, and you finish. Now you cut your bottom shelf in that 45-degree angle. I'm going to cut the bottom shelf here in that 45-degree angle. So essentially what you have is an osteotomy with a shelf on it. You see the shelf on the bottom? So as you slide this over, it has a shelf to hold on to. You can fixate this with screw fixation or with K-wires. But you look at this lateral side here. You see this shelf he's got here? On the lateral side right here. You see that shelf overhang. See how it's down like that? So that makes it a very stable osteotomy. It won't move anywhere when you got the capsule intact. The capsule's not disrupted at all. Now, the other thing you can do with the Wilson modified Katzen was a little different. It's even cooler. Let me show you that. We'll get another bone real quick. Okay, another version of this that I like is actually go into the diaphyseal bone. So this would be more of a shaft osteotomy. And what you do with that, you do the exact same cut. So you're going to start at the top of the bone and go straight down at a 45-degree angle like that. So the same thing as before. See it go through like that. Yep. Then you bring the osteotomy up, and you kind of go straight again, and you're going to go straight through this medial side. And go back in your hole and go straight through the lateral side. So once again, you're kind of left with this kind of cut right here. Okay. Now what you can do, if you have a bun, you can feather this way without having to even having to transposition the head as much. So you go ahead and cut through your medial side first through the same hole. So you got your osteotomy there. So if you look underneath there, you can see from this side here. Come look at the cut on this side here. If you're looking over here like this, from where I'm at right here. If you look at it, you can see the cut like that. You see the cut. So what you have cut, you have the dorsal side cut, and you have the medial plantar side cut. So what you do now is you go into your original hole, and you begin to put pressure this way, and you begin to tether the bone. So what you'll end up doing is almost like a base wedge. So you're tethering it and turning and pushing the head lateral. So you'll kind of start cutting from the hole and tethering. And what you can start to see is the bone will begin to move, almost like doing a base wedge, but you're doing this medial here. So you can come back and tether that out, come back to your original hole, go through there, like before, and you start tethering out. So what you end up doing is you're going to have a cut like this, which is very stable, and it's going to tether in like that. So that's how it's going to do. So it's going to pull you. It's going to give you a lot of correction of IM angle without having to. So even if you kind of push it over a little bit like that, you can tether it like that. Then at this point, you can stabilize your cut, and if you see right here from the side, you can see how much you can. Look how much shelf you have to make a K-wire fixation. You can put a good K-wire fixation. So this cut's going to be like that. Slightly shift it over, like that. And then you can see you got a lot of bone-to-bone apposition there, but look how much correction we got of the bunion here. And then from that point there, you can make your fixation easy right here because you got plenty of room to fixate it. You look right there, you can see the angle of our fixation. Like that. I'm going to go through the bottom so you can see the angle. Now look at the bottom of the foot. This is where it's going to come out like that. So you can even use screw fixation. I found this to be extremely good with just using 2 K-wire fixations like this, and you can actually plantar flex it, or even you can cross K-wire. That's another option. Of course, you do this under the C-arm so that you see where you're at, like that. You can see what we got now. Not only do we have correction of our IM angle up here, we've also got a plantar flexion of the metatarsal head, and no displacement of the head. So this is a very stable osteotomy. If you look at the side here, you can see how stable it is on the bottom here. So the osteotomy works pretty good in the mid shaft as well. All right, that's good.